Thank you so much, ma'am. Very good afternoon to one and all, and thank you for giving me this opportunity to present here. Can I have the presentation, please? Yeah. Okay, so my topic is early intervention and low vision management in children with cerebral visual impairment. So as we all know that early intervention alone for vision is not enough, and early visual rehabilitation definitely helps in overall rehabilitation of the child. So with only visual stimulation, we can improve hand-eye coordination as well. Visual fields improvement will help in walking early, and then will also help in motor improvement. Similarly, visual perception and tracking will improve egocentricity, and then there will be overall development, causing improvement in social behavior and other better response to other therapies. So as we all know, CVI has already been discussed. It is an umbrella term. From an intervention point of view, we need to know what are we looking at, when did it happen, and how did it happen. So like ma'am already mentioned, like if hypoglycemia is there, then and absent corpus callosum, there are lesser chances of better prognosis, but still we have to work hard and we can get there. So as already been mentioned by Dr. Sovita and ma'am, that we have to first classify, and from an intervention point of view, once we have classified into the ranges, whether it is phase 1, phase 2 and phase 3, accordingly we chart after the evaluation, what are the parents' concerns, what are the concerns that the intervention therapist is going to jot them down, and then what are the environmental modifications we can make. After having all of them, then we can decide on the adaptive technology that can also be used. So broadly, phase 1 and 2 can be classified as low functioning CVI, where we need to work a little harder, whereas phase 3 is high functional CVI, where they usually have good vision, but here we have to work more on the visuospatial things. And like ma'am said, that there was a child who was 3 years old, and when they came to us, they did not know because vision was already 624. So these are the cases where we diagnose them later. We even, like I'm from the armed forces, and we had a case who was there in the army, and when we were doing a recruitment, there we realized they just had nystagmus, that too latent nystagmus. And then on retrospective evaluation, we could get a CVI diagnosis or diagnosis of PVL in that case. So we have to be a little suspicious from the beginning. First and foremost is parent education. If the parents don't understand what the child is going through, what the status is, what the visual status will be, and what is the status that is going to, what is the strategy that we're going to apply to improve that vision, we can't go ahead. The parents need to be fully convinced, especially with general ophthalmologists. They would do the refraction, they would do the strabismus, or refer to a strabismologist, but they would never refer to an intervention specialist. That is important, and we need to have that awareness amongst the general ophthalmologists also. As one of the audience has asked, how frequently do we need to reassess? So to frequently reassess, we have all those latency and all those things covered in the CVI range. However, when we are taking the child for assessment, these points need to be kept in mind. Whether the child is fully attentive or not, whether the child is fed or not, if they've eaten their food, they will definitely perform better if they have. If they are not ill, if they have slept or not, and then if there is any fatigue already there. Like ma'am had mentioned, if they're an epileptic child, if they've just had an epileptic seizure, you would have improvement as an intervention specialist, and suddenly they will be back to zero. So you have to start again. And this needs to be told to the parents, otherwise what they feel is that so much of intervention already done, so much therapy already done, and there's no improvement. So we have to do this. Now the CVI range should be filled at least once in every 3 months, and it should be discussed and re-evaluated and rediscussed. So as I said, counseling the parents is very important. We need to tell them that 50 to 80% of the brain deals with vision in some way or the other. So, and there will always be scope of improvement. So you have to give them this hope so that they can work on it. And early interventions mean as early as possible. Like ma'am said, 6 months, within 6 months if you do it, there's going to be great improvement. But 2 to 3 years is the range when you're still expecting good improvement. So ophthalmological treatment, this has already been covered, but just to cover it all, we have to give them glasses, do a dynamic retinoscopy, give them plus glasses if required, management of the strabismus and cataracts and nystagmus, all that has to be done prior to the therapy, but we need to continue the therapy even after. And then there are these newer interventions that have now come in. There is a case report saying that transcranial electrical stimulation helps along with the visual stimulation. There is an RCT which says that acupuncture given especially on the tongue and the scalp, that can really help along with the visual therapy, and there have been statistically significant results showing improvement. Similarly, an RCT has been done on stem cell transplantation and showing a great improvement in these children. But all of this goes along with the vision therapy. There is no replacement of that. So coming to the general principles of early intervention, the first thing is that we need to have an holistic approach. We need to understand how much the child can walk, how much the child can understand. So accordingly, we can grade where we can start, how much therapy we can give. And then we need to understand the visual world of the child. If we are giving them toys on the floor when they're sitting down on the floor and they have an inferior field defect, it is not going to help, and we will just be frustrated with the therapy. So we have to understand their visual field, what are the contrasts they can use, what is the visual grating, what are the maximum thickness of the lines that they can differentiate. When we start therapy, we should already know all of this so that we can work on this and further refine it later. And as shown in this picture, it is important to have a good posture for the child so that the child is sitting straight. With patients with CP, if they're all falling down, it's very difficult to start therapy in them. And we should always try to use therapies which can be replicated at home, because parents can do this therapy for whole day long. They'll be there with the therapist only for an hour or so. So environmental modifications and home modifications that can be done. First and foremost, we need to declutter the house. There should be no extra toys, no extra decoratives kept, no wallpapers, as plain as possible. We can have curtains which can be of a darker contrast so that the child can identify doors and windows in the house. Then, as earlier it was said that when stimulating vision, only stimulate vision. But now that's not the concept. Stimulating all the senses together gets us a better improvement. So tactile stimulation by the father growing a beard, contrast improvement by the mother doing some highlighting makeup, and here we show there's a feeder bottle where we have grated it according to the visual grating of the child, so to make it more attractive, and it has a shiny component so the child accepts it gracefully. We should avoid too many toys. We should present one toy at a time. Coming to visual stimulation, it is a very dynamic and an interactive approach. Choice of stimulus should be as per the assessment. What is the preference of the color, the size of the object that the child will react to. Reaction of the child to each stimulus should be observed, noted, and then we make further adjustments to further engage the child. So start with what is known, engage the child with what is known, and then move towards what is not known, what we can further refine to. Okay, coming to a multi-sensory approach, we need to give all the tactile stimulus, visual stimulus, sound stimulus, as I've already discussed. What would be an optimal stimulus for the child? We should have the correct frequency, the correct intensity, the correct duration. If the child's visual attention is only for a few minutes and you're going on showing them the stimulus, it's not going to work. So give them frequent vision breaks in between. The environment should be good, and refrain from giving visual tasks, especially when the child is hungry, tired, or ill. So here we are just showing that there are two different sizes of the stimulus and different colors according to the preference of the child, and also the visual distance at which the child is going to absorb that has to be noted. Coming to movement, using movement as a tool. So movement is generally there to engage the child, to get the attention of the child. It will also improve the attention span, and we have to keep it again at the correct distance. However, we should always note that all children with dyskinetopsia, their movement is actually a big problem for the child. In that case, the child and the therapist and the object should the three should be absolutely still and calm for the child to work on it. Also, movement can be a distractor. So if I'm showing a toy to the child and there are people moving in the background, it's not going to help. We need to put screens so that the child cannot see any other thing in the background. Then working on the visual fields, we already know that inferior visual field is the one that is most effective because of the posterior parietal defects. So we do not use this field in the beginning. Show them what they already know, and then gradually move from the non-seeing area to the seeing area. Go to the edge of the seeing and non-seeing area. Stimulate the edge as much as possible. Teach them tracking movements. Once they start doing tracking movements, their saccades and pursuits are better. Only after that you can involve the non-seeing area and get it in your visual field. We really need to keep it simple. Show a solid object, a bright colored object in a dark background. Even dark gloves can be worn so that even the gloves or the instructor's hand is not a distractor. And with that, we can go ahead, show them one object at a time, and then always develop a routine. Do the same things every time. It will lead to a visual memory to the child and help her. using familiarities as a tool is very important. So for example, we have this rattle here, which has gratings according to the vision of the child. It has bright colors, and we've been using this rattle to stimulate the vision. Now we can use the same rattle to bring it into their visual field. So familiarity, it's a favorite toy. They will work on it further, and it will be a faster improvement. So whenever adding new information, try to have a familiar background. Coming to high functioning CVIs, where we already have good vision, but the problems are with optic ataxia, agnosia, and dyskinetopsia, and those kind of things, where visual spatial orientation and egocentricity is a problem. So here, tactile sensation has to be used to manage the visuospatial difficulties. Like we see in this picture, the child knows what a 9 is. The child knows where the 9 has to be placed, but they have to use their hands to feel the 9 and then put it there. So this is how they keep practicing this, and gradually their hand-eye coordination improves. Coming to optic ataxia, they are unable to grab a simple bottle. So here what we can do is, we do this Leah's mailbox, and first we start with this Leah's mailbox technique on a 2D scale. So we put it flat on the ground, ask the child to put it on the, put the card on the slit, and gradually make it 3D for the improvement. Now here in this last picture, we see that this child has already overcome the crowding phenomenon and is now able to pick up all the pink sticks from the box. So now here they're working on the sorting of the child. So coming to orientation and mobility, now if there's a problem in the temporal lobe, navigational skills will be affected. So here we have to teach them navigation. We have to first give them a preview. We start with very small backgrounds, just take them from one room to the other and show them all the bright things, all the good visual landmarks and the optimal sounds that can be used to recognize that path, along with bright colors or tactile sensations if possible. Then gradually increase the route. Do it again and again with them. This will give them some kind of a familiarity, and then describe the objects that are being used. Once the objects are described, it will also lead to increase in the cognition. At the end, coming to a communication support, augmentative and alternate communication and assisted technologies. Earlier it was felt that having these assisted technologies, low vision, not the low vision aids, but having these iPads and videos and digital screens showing the objects and telling you about the objects, the descriptors were a no for these children. But now it is seen that the sound sense, the vision sense, if they all work together, it's going to bring a better improvement. So we need to integrate this. This is going to be a visual bonus for the child. Coming to the low vision, we can use all the magnifiers like we use for all other low vision aids. Now this is a special tool that has been made only for CVI children. This is an app. It is easily downloadable, and it is present on Apple. So here we see an object on a black background, and as the child taps the object at the right place, the object grows in size, and at the end it also applauds the child for doing the right thing. So it really helps in building up this. The AAO has a list of such apps and games that we can use to inculcate these activities in the child. As has already been mentioned, an integrated intervention approach is the best. Having all of them under one roof is going to be the best idea for the parents, so that all the therapists can discuss amongst themselves what sensations, what sensory functioning the child is already having, and the others can function on it accordingly. Thank you, and at last I would like to thank SCH for letting me know all this information. Thank you.